Right, so shall we get started?
Mm-hmm.
Yeah, so I'm going to put a slide up. I'm going to share a screen with you. These are essentially things that we're going to address. So the first question I had, can you all see that?
Yep.
Yeah. Yep.
We had a question, I think it was from, how do I manage programs for athletes whose races? Now, Becky is an athlete, I believe. I don't know if Becky is.
Yeah.
And I think and this is something where, you know, the collective understanding would be good. So if you want to chip in at any time, guys, don't think this is just me sitting there talking imparting, which I'm going to do. But if you've got any ideas in terms of other things that the people that have joined us can try, that would be really useful to get your input, your understanding. So from my point of view, I think from a ones, I think the biggest issue is going to be getting full time. You know, I think it's going to be from the swimming perspective, access to swimming pools. Unless you're Alistair Brownlee, who's got an endless pool in his garage, I think that's probably going to be the limiting factor in terms of managing your triathlon training. Is getting access to water to swim. And I think the rest from a program perspective, I think just trying to maintain some degree of fitness and to maintain some elements would be probably the most pertinent part of managing your clients whose races have been cancelled. What would you say, Martin, in this situation from a strength and conditioning perspective?
So most of the S&C stuff I do is usually I don't really work around the actual like programming of races. I mostly work in the rehab side of it.
Okay. Anybody else got any?
In terms of triathlons, I have no idea.
Anybody else?
Can I just say that personally, I think a lot of the issues that I've had with some of my clients lately is psychological, because they're dealing with, you know, that sort of disappointment, or they've been working hard to get to that point and all of a sudden it's just gone.
Yeah.
So I think that's a big part of what I've been doing quite a lot with people that I've been working quite closely with.
And how have you found managing their disappointment? What have you tried in terms of?
I think just looking at it in terms of it's not necessarily gone forever. It's just going to use this time now to make it more beneficial for long term. What can we do in terms of the training that, you know, it's been put on pause, but it's not stopped.
Yeah.
So what can they improve?
Yeah, well, I think this is it's a good time to reframe, isn't it? And to try and not get people to refocus on things that perhaps they've neglected.
Yeah.
That race preparation period. You know, when you're peaking for a race, you tend to find all the additional stuff that you're probably doing in the off season goes out the window. So
agreed.
Work and you're running drills, and I think going back and reframing things and suggesting to people that this is a time where we're going to address some of the issues that you've had previously. You know, that's strength, mobility. I think that would be probably a good way to manage the psychological impact of, dealing with these things. I mean, we've got quite a few guys that were preparing for bodybuilding shows, powerlifting competitions, and it's the same situation for them. You know, that a lot of them have started prep. A lot of them were 3 weeks in, 3 weeks before their comp, and that was cancelled. And they're in great shape, but they've got no show, no sort of competition to compete in. So I think reminding people where we are. You know, I think the situation we find ourselves in is unprecedented, and yes, things will get back to normal, but it might just be an opportunity to take a step back and to try and address some of those issues that previously they've neglected. You know, that might be running drills, that might be cycling stuff. Obviously, the pool's an issue, unless you've got access to open water or endless pools. So that would be.
Look at it as a positive, Aaron, as well. From a psychological point of view, I think you've got to try and make your clients aware that they can you can see it as a positive. You've got to try and take the positives out of every scenario. So, like you said, working on things that you are currently not the best at, you've got longevity now. So you've got to look at the bigger picture, and you've got a longer time to prepare now and improve before things are starting to get released again in terms of show dates, competition dates, events.
100%.
So I think managing your client's perspective psychologically, you've got to take positives out of this situation. So for me personally, my preparations have been put on hold. I don't really know. Well, I do long term. I know what my goal is long term, but in terms of what I were working towards, that's kind of come to a bit of a standstill. But now I've got time to work on my health, my fitness, my mobility, my flexibility, my posing. So when things do get released again, I'm going to be in a better position to move forward and be better than what I would have been if things would have been available in 3, 6, 9 months' time.
Yeah.
Bang on that, absolutely. I would say, mate, I will looking to compete this year in natural men's physique, which ain't going to happen. But I had a lot of work to do, so I've got more time to prep for that now. So I'm just seeing that as a positive.
Yeah.
The same with the clients that I had that were training for the London Marathon. They've got more time. You know, if they were struggling to get those long runs in, they've now got more time. They're going to be in a far better position when that time comes round than what they would have been. So they don't feel like they have to panic now.
Yeah, exactly.
And I feel like what you said there is just turn everything into a positive.
Yeah, exactly. And that comes with on the injury side of things, because I think when you're in competitive sport or competitive training, everybody's sorry about I'm chewing.
That's right. You can't hear it. It's not triggering my mesophobia.
I think 90% of athletes, competitors, are carrying some form of niggle injury.
Yeah.
So this gives them more time to, like you say, work on their on their weaknesses, the mobility, the strengthening procedures, the stabilizing movements, finding the root cause of what issues are, and sort of really trying to dig in on getting them fixed.
Yeah, definitely. So Aaron's been helping me recover from a herniated disc, which has massively hindered my progress in terms of prepping for the show, just because I can't lift anything heavy, because every time I do, my back goes. And every time I pop back in and see it, Aaron is like, too much, too soon. But that's because I'm panicking because I didn't have that much time to prep. Whereas now I've got more time to focus on looking after my back rather than rushing into training.
Yeah, absolutely.
So I'm only seeing it as a positive, to be honest. I've got more time.
Yeah, I think that's a really good point. I think it just gives you an opportunity to reframe your goals and take the pressure off yourself in terms of, you know, trying to rush through something that you could do in 6 months, but be better done in 12 months.
Yeah.
100%.
Right, shall I move on to the next question?
Yeah.
Yeah. So next question. I'm just going to share this with you. So this was from Amy, I think it was, wasn't it, Amy?
Yeah. It's quite a unique one because she can't do anything, even leg extension, to like strengthen her quads. She's the most beginner of beginner, like never stepped foot in a gym ever. Yeah. So she's literally like started from scratch, which is good because you can build her from the ground up. But it's just trying to find stuff that she can actually do, because even walking triggers it.
Yeah, so I think the thing you've got to remember that, so in terms of like overweight clients and anterior knee pain, there is a strong correlation between knee mass and knee dysfunctions. And typically, it's usually the tibiofemoral joint, it's usually the actual knee joint itself. But a lot of them get problems with the patellofemoral joint, which is the connection between the patella and the femur underneath. And I think some of it's biomechanical. You probably find with a lot of these clients, depending on how overweight they are, you'll tend to find that they often drop into a knee valgus position, so the knees drop in slightly. So biomechanically, the patella's not running in an efficient alignment, and that starts to cause problems. I think the other thing is adipose tissue produces cytokines. So cytokines are inflammatory protein signalers, and what you'll find is it's really common because of the amount of adipose tissue. It might have been the type of foods they're eating, simple sugars, and the inflammatory effect of simple sugars. I think in those situations, managing your client, not just from a biomechanical perspective, but from a diet perspective, is probably going to yield better results than if you just went down the biomechanical route alone. I think if we're talking biomechanics, because obviously nutrition's outside of my remit, and wife is who could probably chip in at some point with the anti-inflammatory stuff. There is no question. But in terms of biomechanics, how would you get them back to the point where they're able to squat and do the leg extension, do there? I think breaking it down to the point where, I mean, for me, I'd be inclined to get them to do some form of sit to stand. It wouldn't necessarily be a squat, onto a box, raise or lower based on how uncomfortable the knees are. So some sort of box squat type movements, which you can then reduce the height of the box, starting to move through more range as the load tolerance improves. And working on some of those stabilizing muscles around the hips, the abductors, building some strength into there to try and pull the knees from that valgus position, from that not knee position, into more of a normal alignment position. So I think it would be just a case, leg extensions, in my experience, and again, Martin, if you want to jump in here with your S&C hat on, leg extensions, because they're an open kinetic chain exercise, they tend to put a lot of stress and strain on the ligaments around the knees. Whereas closed kinetic chain movements, things where your feet are in contact with the floor, you tend to find compress the joints and make things feel more comfortable in those situations where you've got, pain on walking. But I think addressing it just purely from a biomechanical perspective probably is you're missing a trick there in terms of the whole. Hello, Uris. I think you're missing a trick there in terms of addressing the other causes that might be causing their joint inflammation.
Yeah.
Simply be a mechanical kind of issue.
Yeah,
Anybody else want to add anything onto that in terms of
add in with the TRX as well?
Phoebes has got something.
That's what I found helped with one of my biggest clients. So
Right.
do it in a box and then getting them to sit on the box, use the TRX as well. So it's a bit like a TRX box squat.
Yeah.
Helped.
Yeah, just use that assistance to help you up.
Yeah, definitely.
Yeah.
I would say, just because of obviously we can't see the client and be there to support during the exercise, so you can't really see if they're doing it right. Maybe focusing more on what Aaron said about the nutrition side.
Yeah, that's what we're doing anyway. She's 15 kilos down already, so that's
really
making
good.
a massive difference. She was like 127 when we started, so
Right.
she's about 5'2", I think 5'3". So she's a big.
Does she want to go into powerlifting?
Perfect for it.
Right. So does that answer your question, Amy?
Yeah, definitely. Thanks, guys.
You happy for that? The other thing I think, one of the things I think we should try is you get meniscal degeneration with the weight bearing. So as the compression on that meniscus starts to increase the pressure on those inert structures in the knee joint, you often find you get some degeneration in the meniscus. Now there's chondral defense exercises that you might find quite useful to get some improve nutrition to the meniscus and to alleviate some of the symptoms. And that simply just sitting there, swinging the leg forwards and backwards, very much like you do. Do you know a pendular exercise for the shoulder? Do you know what I mean by pendular exercise?
Yeah.
It's a similar principle with the lower limb. So when she's in periods, and she's sat on a chair, swinging her leg forwards and backwards, sitting on a reasonably high stool so she can get that full range of movement through the foot. And that with nourishing the cartilage. It needs that regular compression distraction. It's a bit like a sponge. I always think of articular cartilage like a sponge. And you tend to find when you compress the sponge, it's fluid out of the joint, or fluid out of the cartilage. When you distract the joint, when you pull the joints apart, you find that the sponge sucks the fluid back up, and that's how cartilage gains its nutrition. So the research done now in terms of osteoarthritic change, compression and distraction are actually really useful adjuncts to manage, OA knees, OA hips, before you get to the stage where you start to sort of go down the surgical route.
Oh, cool. I'll try that. Thank you.
So chondral defense, swinging the leg, and then some compression and distraction. But as Phoebe said, maybe using body weight off, reducing the height, the depth of the squat, and then building it back up to the point where you've then got the ability to be able to move, for a normal range of movements.
Yeah, perfect. Thank you.
Perfect. Right, next one then. I'm just going to get the next one. Next question. So we've got a couple of questions now about neck and lower back pain assessment and management. So I'm going to try and give you a bit of an insight into how I'd manage this, or how I've been managing this remotely online. So I tend to classify, back pain is a really difficult thing to diagnose. And, even for therapists, I think the therapists out there, Aaron, you'll probably echo this sentiment. It's multifactorial. It's very difficult to pinpoint tissue causing symptoms. And I think rather than trying to do that, because your guess is probably as good as mine, and even with the use of MRI scans, we still aren't able to pinpoint the tissue causing symptoms in lots of cases, which is why back pain and surgery are so generally unsuccessful. So what I tend to do is I try and triage my back pain clients. So there's 3 subcategories I tend to use. The first one would be mechanical, which is back pain. So they've got back pain. It doesn't radiate into the glutes, the hamstrings. It's simply in the back. That might be one-sided, it might be both-sided. So that's mechanical back pain, which is back dominant. You've then got mechanical back pain, which is leg dominant, which is what Aidan had with his disc injury. And that's where you've got symptoms into the glute, into the hamstring, into the calf, maybe into the foot. So that's what we class as being radicular pain. Pathological back pain, which accounts for about 1% of the people that we typically see clinically. So when I'm asking questions of people, and this is whether it's online or face-to-face, my initial process is to triage their back into one of those 3 subcategories. Now, disc prolapses and radicular pain, that needs to be managed a bit differently, and that's probably about 5% of the people that you're going to see will have that kind of radicular pain. Pathological back pain, that needs to be referred on. Those are things like, we'll talk a bit about in a minute about, there's a question about how you screen for pathologies. So I'm going to talk a little bit about red flags and things that you might ask questions of to rule out the possibility this is something other than just a simple mechanical back problem. And then once you've subcategorized those into their respective categories, so mechanical back pain, which is leg dominant, and then pathological, which you're going to screen out, then I think managing those tends to be about reloading and mobilizing. So if we take the mechanical back pain, if they get pain on forward flexion, then I will be loosening off their posterior chain. I'll be loosening off hamstrings, glutes, and working through from there.
Mm-hmm.
I get mechanical back pain, which is extension sensitive, so they get pain on extension. Then I'll be working into rec fem, psoas major, so the anterior chain, the anterior structures.
Okay.
I'd be using those, simple mobility exercises. It might be a bit of stretching. It might be a bit of mobilizing their spine on a foam roller, but it would be taken into consideration their pain sensitivity. So flexion pain or flexion sensitivity, mobilise the posterior chain. Extension sensitivity, mobilise the anterior chain, so psoas major, iliacus, recfen, all those muscles at the front. And that's, to be honest with you, you'll find that you guys that are PTing will have as much success using that approach as your therapist will do. You know, I think a lot of the stuff that you see, the day-to-day stuff, the day-to-day back problems, will resolve pretty quickly if you can start to do some stuff to, you know, open up the hips or open up the back. And I think you'll find you can actually manage the majority of stuff without the need for an onward referral in that situation. What does anybody else want to say about that, Aaron? Have you got any thoughts?
Yeah, I totally agree. As well with the mechanical kind of back issues, obviously they've been reoccurring from, you know, years, a matter of years. So it's about changing the movements back into, you know, the proper way. How should they hip hinge, for example, for back pain? You have a look as PTs and S&Cs as well. Even though you're not in a clinic giving an assessment, you physically watching them do an exercise is an assessment. Okay, so you can have a look at their lower back pain, their flexibility. Can they hip hinge? Have they got tight hamstrings? Just by you correcting them will probably be more efficient than somebody just giving a little bit of a massage.
Absolutely.
So yeah.
Yeah, I mean, a lot of the stuff that we do clinically, you know, the hands-on stuff, it's about pain modulation. It's not designed to fix people per se. It's the rehab stuff that you do afterwards. From a PT perspective, you know, you guys are as well placed as I am to be encouraging clients to try and manage their symptoms, particularly in this situation where there's no access to physios and osteopaths and chiros at the moment. But yeah, I think you're in a good position. Now, Lucy was asking, she's got a couple of clients who've got spinal stenosis and some bulging discs, and they're wanting to build muscle, but home workouts are limited because of that, their inability to be able to spinal load. Would that be a reasonable summation of your question, Luce?
Yeah, like, basically what we're doing with the gym is they're basically offered anyone who wants to keep their membership going, they just keep, well, they pay for it, they can still basically get like classes and online sort of PT from us guys. So they've basically just distributed them out. They've asked which PT they want to help them out. I've got all the females, they've all come to me. So a lot of them have got sort of weight training resistance backgrounds, whether they've worked with another PT before or they've herniated the disc, which is like a new injury, but they want to keep up with that. So I've asked them what the goals are, because that's going to be very dependent on whether I'm sort of how I'm tailoring their workouts at home. And a lot of them want to basically keep up with the strength, keep up with resistance training, but the majority of them don't really have anything. Like, I think a couple of them have got very light dumbbells or resistance bands, but that's pretty much it. And some of them have like nothing besides like a glute band, and that is it. And I've asked them what sort of their capabilities are. Some people might say they've got a lot that they can't do, but they actually can. And a lot of them say basically they can't really do much. So I'm struggling to sort of program efficiently, really. So
are they struggling to do stuff based on their spinal issues or based on their lack of equipment?
Bit of both. So, for example, one, you've got a lack of equipment. So I was basically asking them about, you know, being in that sort of like press up position, because there's a lot you can do in that sort of position, basically planks, press ups, things like that they can't do, especially the lady with spinal stenosis. She says that can cause a lot of issues. She's got a lot of kit, in fairness to her. It's more the other ones who just said got a lot of low back issues or the actual injuries themselves. They've got like next to nothing at home.
So by spinal stenosis, I'm assuming that you mean they've got a narrowing of the cord is. That's what I understand.
Yeah.
So
What was that? Yeah, I'm struggling to hear.
Yeah, you've gone a bit funny, mate.
Yeah, I've got that. Since Matt joined.
Turn your volume.
Fucking everything up.
He's wrecking the podcast.
What I do.
Right, so you hear me now?
I'm still struggling.
Let me see if wait, let me put my headphones in, see if that helps. It might be my computer echoing.
How's that?
From no audio to all the audio.
It is.
Yeah, that's loads better.
It's my fucking
It was
shit
maths.
computer.
The one person joins and he wrecks the entire webinar. Thanks, Matt. I'll sort you out later. Right. So spinal stenosis. Is she quite an elderly client?
I don't like to ask, but I would probably put her at mid-40s.
Right. Because it's I mean really old, as Dan just said. That's not really old at all. Yes. Spinal stenosis. I mean, unless she's got a congenital issue which has caused narrowing of the spinal canal, or she's got some osteophytes, with little bits of bone that grow into the spinal canal. Generally speaking, you'll find anything where you're putting them into extension, because it compresses the spinal canal further. So planks, those kind of core exercises you tend to find, they won't like those because it's basically causing more compression onto the spinal cord and more pathology. So I think in those situations, a flexion-based approach will be better. So I'd be inclined to get them into, how much stuff have you covered in terms of like core stability?
In terms of what, sorry?
In terms of core stability, so transverse abdominis work, that kind of Pilates-based stuff.
In terms of what do I know about it, or in terms of?
Yeah, what have you covered with her, or what do you?
In terms of what I've covered with her, or what have I been covering in general?
What do you know in general?
It's all pretty much basics. I wouldn't say I know a lot, but more than the average Joe. Pretty basic stuff.
From a core stability perspective, there's your abdominal muscles obviously are in different layers.
Yeah.
Seemingly the most important of the muscles is a muscle called transverse abdominis, which runs like a corset. So in a crook lying position, so lying on the back with the legs bent and the feet flat on the floor, I would be inclined to start to introduce some basic motor programming, so getting them to activate that muscle, because that's a challenge in itself. For a lot of people with existing back problems, they'll struggle to actually activate transverse abdominis because there's almost like a neural inhibition of the brain switching off, because every time you contract it, it hurts your back. I'm trying to teach you some abdominal sort of hollowing exercises, drawing in to activate transverse abdominis in that crook lying position, lying on the back. And then I would be inclined then to start to use the arms and legs as weights to increase strength, arm loading exercises, but done in a lying on your back position, so you're not into that extension.
Okay, yeah.
So taking back from that, and I can send you some stuff. I mean, what we're planning on at the end of this is maybe setting up some sort of closed Facebook group for the guys that have participated. And then if there's any questions that arise outside of these webinars, we can answer those questions directly and send you bits and pieces across to try and help out a little bit.
Yeah, sounds good.
Yeah.
Yeah.
And with the other stuff, tell me a little bit about what the issues were there.
With the what? Sorry.
Did you got some people with disc injuries or bulging?
Yeah, so I've got a few with just general sort of lower back issues, but we've worked around those pretty well. It's just a new one that I've got through today. She's been exercising for quite a while. So what she was doing, and she's recently got the herniated disc. She was saying what she was doing then was she was easing off for intensity in the gym. So she was going to lots of sort of high impact classes and doing a few of the resistance machines. So she eased off that. She was just sort of doing light treadmill walking, just really easy cardio, and then she was actually swimming for her main source of exercise. But because she can't do any of that now, she feels quite lost. So she wants to keep up with the fitness, keep up with the strength, and keep up sort of keeping active, really.
So I think in that situation, and Aidan might be able to jump in and help out a little bit here. I'd be trying to reframe what she's. So at the moment, she's going to have to put her fitness goals on hold a little bit and address issues with her back. Because with the best will in the world, if she tries to continue training like she has been, with the HIIT and the stuff weights in, all that's going to happen is it'll get entrenched and the pain will get worse. It'll get more irritated.
Yeah.
So I would be inclined to kind of try and reframe her fitness goals and try and direct her more into some disc if she, I mean, has this been diagnosed with an MRI scan, or has this just been something that she's seen?
The way she's phrased it, it looks like it's been properly diagnosed because
Right.
the way I've not asked, but the way she's phrased things to me, it sounds like it's been an ongoing issue and something that she's kind of getting proper help for. It's not just something she's self-diagnosed by the sounds of it.
And has she got leg pain, glute pain?
Not that she's mentioned. I mean, I need to just get some more sort of details from her because I've only actually got in contact with her. I think it was yesterday. Cause she's the one who's just gotten. Whereas the others I've been speaking to, well, since we shut, she's someone who's just joined up. So I don't know that much, but I could obviously do a bit more digging with her. For sure.
Yeah, so I'd be inclined to find out what her symptoms are, whether she's got pain, leg pain. If she's got pain, the flossing stuff that Aidan was talking about is a godsend. Tends to happen is the nerve becomes entrapped, and then because the nerve sits within a sheath, it can get stuck to the sheath, which then cause problems with mobility of the nerve itself. So there's some stuff by David Butler. You want to jot this down? David Butler's a neurophysio. This stuff's freely accessible online. And he does a lot of stuff with regards to neural flossing and adverse tension. So a lot of the tests that we use clinically, so do you know what I mean by straight leg raise test?
Yeah, off the bed.
Yeah, off the bed. So lying on the bed, lifting your leg into the air passively. So you as the therapist lifting the leg into the air. So that's a neural tension test. So it's one of the things that we use to diagnose sciatica or sciatic nerve irritation. And what you'll find is that that test becomes a floss. So that becomes the way that you address your nerve tightness. And from Aidan's perspective, when Aidan came to see me with his disc prolapse, he had this nagging glute/hamstring pain, which pretty much within about 5 minutes.
Oh, mate, it was ridiculous. Absolutely ridiculous. I mean, from considering where I was, I mean, I had 12 weeks where I couldn't walk. I was on crutches for 12 weeks. The pain was absolutely incredible. It was brutal. But then, like, as soon as you showed me that flossing technique, I mean, I have to do it sort of like 3 or 4 times a day at the minute, still, just to keep my leg moving. But it works every single time.
Yeah.
And that's only due to the amount of exercise I'm currently doing while teaching all these online classes.
Yeah.
If it was just general day-to-day gym work, I'd be absolutely fine by just doing it once a day. I'm sure of it.
Yeah. So it's just the sheer volume of squats that you're doing currently.
Yeah. Jumping up and down like an idiot.
Maybe you need to think about changing your programming, Aidan.
Possibly.
Were you going to say something, Phoebes?
Yeah, Nathan's just got a video up, and I actually do that to help with my sciatica leg pain, but I didn't know it was called flossing.
Yeah, so if you Google or YouTube sciatic nerve flossing, there'll be a number of different videos, and they're all pretty much the same principle.
You do a lot of heavy glute hip thrusting though, Phoebe, don't you?
I know. It is an underlying issue, though, that I had before I started going heavy.
Yeah. And I think it's one of those things. We underestimate the impact of the nervous system on range of movements, on joint restrictions. And I think, as good PTs and good S&C coaches and good, you always need to be mindful of the impact of a tight nervous system.
I think as well, like going back to a client's goals, she needs to be realistic at this sort of stage.
Yeah.
When my back went, I was in pretty decent nick because I was prepping for that show last year. I was about 2 months away from show date. So I was in probably best shape I'd been in for a while. My back went, couldn't train, couldn't do anything, couldn't hardly a bloody walk. So you start drinking a bit more, don't you? You start eating loads of shit. And then I think you get to a point where you've got to be a bit realistic in like what your goals are going to be. So just basic mobility work, swimming, that helps.
Yeah.
And then just started setting little tiny goals each week, month, 2 months. And it didn't take long. Once you got me mobile again, showed me a few new things, I was back up and in the gym more or less immediately.
Yeah, I think was it that afternoon. I think it was, wasn't it? I said,
Yeah, you weren't right happy about that, were you?
I wasn't. Yeah, literally treated him. That afternoon he's in the gym doing legs. I was like, no, please. Just an accident waiting to
Yeah,
happen.
about an hour
What
after
you
you
think,
treated
Aaron?
me.
Adrian's your worst nightmare client.
Yeah, he's one of my worst nightmare clients. What were you going to say, Matt?
I was just going to say, when people are consistently doing compressive exercises posteriorly on the pelvis, that can sometimes create like a concentric orientation of like the piriformis, which obviously, like, what is it, like 20% of the population, what the sciatic nerve runs through the piriformis.
Yeah.
That guy ends up pulling into a position of external rotation, and it's more biased towards that, then the chances of that individual getting sciatic symptoms are going to be increased.
Yeah, and I think piriformis syndrome is one of those things that expanded around a lot by therapists. Actually, as Matt said, 20% of the population, the sciatic nerve runs through the middle of piriformis as opposed to underneath it like it would do in normal people. So I think the same principles apply, whether it's piriformis syndrome or herniated discs. I think ameliorating her leg symptoms, if she's got leg symptoms, would be my first priority. Because once you've got the leg symptoms under control, you can then start to think about doing normal, more normal kind of physical activity.
Might sound daft as well, but like their breathing strategy and what they're biased to in terms of the breathing can sometimes influence that. Because if someone's really strong, they're going to be in a position of exhalation or more towards a bias of exhalation, which would basically be like a upwards pump handle of the rib cage and a downwards tip of the pelvis anteriorly, which then you're going to get internal rotation bias at the femurs, which is then going to encourage those obturators and the external rotators at the hip to bias into external rotation, and you get like a secondary layer of compensation happen there. That's another way that it can happen as well.
How would you address that though with breathing? Then, Matt?
Basically see whether they can go for a full breathing excursion in terms of full inhalation, full exhalation. You're gonna get a clue as to which one that they're in based on their intersternal angle. So the angle presentation of the bottom of the rib cage. If someone's wider, that's going to be more indicative of them being in an exhaled strategy. If it's narrower, that's going to be more indicative of them being in an inhaled bias with like a posterior shift of the spine. That's going to basically so if they're inhaled, that'll have a posterior tuck of the pelvis and more of like a flattened out lordotic arch and a bit more of like a counter-nutated sacrum. So they would have good external rotation capacity at the hip. But if it was the opposite and they was compressed and they was exhaled, they would have a limitation there instead. Does that make sense?
Yeah. And do you think in terms of, I think from a situation that we find ourselves palpating the ribs now at the moment. from a stress perspective, I'd imagine, when you're in pain, I would imagine you're probably in an
lifestyle could impact that, sure.
Yeah. So I think, some breathing strategies. And again, I think if we close Facebook, I'd be more than happy to jot something down there or post something on there. Some ideas about breathing strategies.
Definitely.
Yeah, thank you, buddy.
No problem.
Are we talking more diaphragmatic breathing now? Just training of the breath? Yeah.
Potentially. If someone's like breathing bias is going to be kind of determined by their own morphological structure. So what you're kind of born with at birth, like that's going to be combined with what we do in terms of an exercise strategy as well. So if we could have someone that's a narrow intersternal angle that does a lot of strength training, and that becomes a little bit wider based on their exhaled bias through their compressive training strategies. But we could also have like the opposite end of that, where someone would be a wider intersternal angle, which becomes more narrow because they might do a lot of like Olympic lifting, and they might have to keep an upright posture and an inhaled diaphragm. So if they inhale, then their spine's going to have to shift back, their rib cage is going to have to expand, and the changes occur at the bottom ribs because they're the ones that have the most ability to move because they're not fused to the costal cartilage.
Mm-hmm.
So it's like that presentation will give us an idea as to what strategy their body's going to choose, because it's just finding a solution to whatever training problem that they're putting onto it. Ultimately, it's still going to take oxygen in no matter what, because that's what we've got to do to survive.
And then to address that, Matt, would you be trying to encourage them to an inhalation pattern as opposed to an exhalation pattern? What would you?
So you could pick. Yeah, so that's a good one. So you could pick exercises which are more biased to compression or biased to expansion. So it's like if we, for example, I don't know, said that we were in a split squat stance.
Yeah.
If we, for example, shifted the hip on the right, on the back foot forwards, that would expand that posterior hip on the right whilst compressing the anterior hip on the left. Or vice versa, we could take that exact same split stance, put the front leg further forward, which would create a compressive strategy on the back of the forward leg, and a compressive strategy on the anterior of the rear leg. So it's just manipulating the exercise for either an inhalation or an exhalation bias. Load's going to come into that as well, because the heavier you go, the more you will be compressive by nature, because for generation of force, we need to compress, and we need a stable environment to produce force from, which is yielded by inhalation and bracing of the core.
So this is more than just.
That makes sense.
Yeah. This is more than just breathing retraining, then, isn't it? It's actually.
Yeah. So that's how that's like a holistic global of like how breathing ties into all movement.
Yeah. Any other questions on backs, guys, before we move on?
No, thank you.
Right, so the next question, this with you. So we had a question about, was this for you, Becky? That you're managing your back pain clients whilst via email. Is this one of your?
Yes.
Yes. So I think emails are, whether or not, I mean, you're now more tech savvy now. You've now used Zoom.
Yay.
So I think what we're doing from an online perspective is I use Zoom, WhatsApp, video calls, FaceTime,
because I think
you need to be able to see your client, you need to be able to see your client moving. I think to manage it remotely via email is very, very difficult. And I think as much as I think the need for a clinical assessment isn't so much online, I think you still need to be able to see them doing things in order to be able to work out what it is, where they're changing movement patterns, where they're trying to get around problems. So you've answered your question by coming onto this webinar because you now have access to Zoom. Going forwards, using this as your platform to do your consultations will work much better. You can see clients in front of you. What does everybody else think in terms of their, because all you guys are doing online stuff at the moment, aren't you?
Yeah, it's been working quite well, to be fair. Like online PT sessions, I think initially these sound like they're going to be a bit naff, but as long as you're like giving them the same care that you would be, you're just not able to touch them like you would be in a PT session, not like that. But everyone seems to be enjoying them. Like it's not, I think it's giving people the accountability that they're missing from the gym as well. Because obviously, like when you go into that gym, you're in that environment to train, so it's hard to kind of get that when you're at home. So I think it's helping them from that perspective.
How have you all approached that kind of motivation stuff at home then with your clients?
Managing expectations.
In terms of what, Matt?
Well, just that they're not going to get the same level of like progress in this environment. But kind of like what Nathan said earlier, this is an opportunity to kind of, capitalize on the things that you don't get time to do normally. And it's like if we're in a position where we're consistently doing the exercise that's fucking us up, quote unquote, then it's like we've not got that at the moment, so we can fix the stuff that we need to fix and go back and hit the ground running. So you can look at it from that angle.
I find that reminding people that this is just a short period of time, and once this is over, life is going to continue as normal. And if you don't put the work in now, then you're going to feel it then.
I think what a lot of people get confused with is motivation and discipline. So
Yeah.
I'll be honest with you, I've not been motivated to train any day this week at all. But it's not motivation that's got me out of bed and got me training, it's discipline.
Mhm.
So
Smiling there.
I love that.
So what I've said to my clients and what Phoebe said to her clients, we wrote like a little bit of a to-do list in terms of psychologically how you can be setting yourself up to train at home, and that is not doing anything any differently than what you would be doing when you're training at the gym. So still eat your pre-workout meal at the same time as you normally would eat your pre-workout meal. Still listen to the same music. Still get changed into your gym kit. Still get your logbook out, write your program down, what you're going to do, and still attack that session like you would be attacking the session in the gym. Don't just still be in your pajamas and your slippers and think that you're going to be able to go and do a training session at home like you would be at the gym, because you just can't. So I think
right is that. It's keeping routine, isn't it?
Yeah, it's about keeping a routine and trying to program it as best you can for the situation that we're all in.
I've been quite fortunate with this because I've got quite a lot of dedicated clients who wasn't prepared to use this as an excuse to just slack off. You know, some had made some really good progress and wanted to keep that going, which I think is a big part of it, really. If you've got that type of client, they'll do what they can to keep motivated and keep going. So with a lot of it, I've managed to keep the majority of my clients in at their set times that they would have on a weekly basis anyway. Those that are working from home will still say maybe finish at 5 p.m, so would still train at 6 p.m.
Yeah.
So I've managed to keep their routine the same as what it would be if we had the gym.
Could I ask a quick question? Is that all right?
Yeah.
So I'm a final year sports therapy student. I've got a final exam next week, and what we have to do is got like a subjective and an objective, and then come up with a treatment plan for a client that we'll meet on the day. And I was just wondering, the subjective is going to stay pretty much the same, but the objective and getting them, obviously we can't do any real proper physical examination. So if you've got any tips on any kind of objective examination that you do with a client.
Yeah, so I think, and again, PTs jump in if you feel the need to, because I think what we teach students as undergrads is a basic framework. I think what you find from an assessment perspective now in comparison to what I did as a student is very different. I tend not to use, so we're examining the hip, I'd be lying a patient on the back and I'd be taught to bring the hip into flexion, extension, abduction, adduction, internal rotation, external rotation.
Mm-hmm.
Now, unfortunately, human movement isn't in those linear planes. And
right.
When you learn to do, you're learning a routine for a purpose, but that routine becomes quickly obsolete once you start to see real world problems that aren't in your textbooks. So my advice would be to find, if it's a lower limb injury, I'd be inclined to get them to do some form of squat, some sort of split squat, depending on whether it's a bilateral problem or unilateral problem. If it's a upper limb problem, I'd be inclined to move more into sort of like some form of a shoulder loading type movement. And I think you'll get much more from that, from watching them do movements, than you will by performing it.
So like a compound movement pattern type analysis rather than just a singular plane.
Yeah.
Okay, that's useful. Thank you for that.
They're called, if you're looking at like YouTube and stuff, functional movements. What you want having a look for. And I think we have to teach you this way because obviously we have to give you the ability to be able to have some routine to sort of drop back onto.
Mm-hmm.
That routine, once you get out into clinical practice, becomes just a routine. And I don't think, even personally, I don't get much from doing those linear movements because that's not where people think. It's in the outer ranges of movement where you start to get problems.
Got you. Yeah.
Matt, Uris, Aaron, anybody else want to jump in and offer any? Martin?
Yeah, I pretty much with what you've just said, really. I think that when you start to understand that movement's kind of all just one sort of rotational looking movement with like expansion, compression, and rotation at some degree, we just have these linear planes to like use as 0 points or reference points so we can have a conversation about it, basically. It's like a map.
Yeah, I agree with that as well. It's a bit like, you know, it's another string to your bow, you know, painting the whole picture. You know, if you get them to do a functional movement like a squat, as well as you talking to them for the assessment as well, you put them two together, you won't go far wrong with what's kind of wrong as such with a pain or issue.
That's
a different approach. I just wanted to top up on previous one. So all this environment is perfect to build your emotional fitness. You can give as many routines, as many whatever not you want to give to your clients and tell them this is great and whatnot. But if they don't have perception of why they have to do it, how good is it going to be, and more importantly, why is that going to be damaging to them in long term, if they skip that, these are the main parts that anyone should be addressing straight away now, because you can't see them and you can't be there. So you need to develop them emotional attachment to actually do shit instead of just thinking about it and having a little routine. You know what I mean?
Yeah.
So like Nathan was talking about, schedule, dress up, show up as if you are in gym.
Yeah.
So this is the best time to build that. And then you give them strategies. Okay, this is how you do it. But if you don't get to the point that you will do it, none of this is like quite relevant. Yeah, it gives us knowledge, it gives us skills, it gives us tools. But if we can't sell it, if they can't buy into it, why is this extremely important? So not much going to happen. So I think that's probably one of the things that people overlook at the moment, because this is the best time to build that up.
Thank you very much.
Does that help, Harry?
Yeah, that's great. Thank you.
Right. Any other questions on the back? Shall I move on to the next question?
Will you just go over the red flags, or are you doing that later?
Yeah, I'm going to do that. I think that's the next one.
All right.
Aaron, sorry, buddy, I'm going to have to run, mate. I've got a client at 1.
No problems, Aidan. Thanks for joining us, buddy.
Thanks for this, mate. Cheers, everyone. Take care.
Cheers, pal.
Cheers.
Yeah.
Right. So next question is, how do we assess for pathology? There's a question. I don't know who posed this question.
That was me.
It was you.
Yeah.
Who's you?
So I've got Martin. So
Martin, sorry, buddy. I can't see you talking.
So like, basically, I know how to do some lumbar and cervical quadrant tests to rule out like disc-based pathology at the neck or lumbar. But part of that, if people are coming to us with like nondescript pain, that I feel there might be something pathological in nature. I don't have the diagnostic capabilities currently to know whether that is something I can work around them with, or whether it is just a straight referral.
Yeah.
So I am insured to work with some pathologies, but not like acute, active clinical pathology.
When you talk about pathologies, I mean, my understanding of pathology is that if we're talking about neck and back pain, there's an underlying disease process that's taking place that's causing either referred pain into the spine, or there's potentially, you know, some sort of cancer that must metastasized into the spine. What's your understanding, your interpretation of pathology, so we can make sure we're on the same page?
So I meant, so generally when people are at the minute sort of self-diagnosing anything in it, whether it is their back or their knee or shoulder, are there anything we can look for so that we know whether it is a straight referral, any sort of simple visual assessments we can do to help rule out anything serious and know whether we do have to refer to physio, osteo, whatever it may be, or whether we can work?
So there's a flag system that we use as therapists, and when we take a case history from clients, what we're doing when we're asking those questions is we're trying to screen out pathologies, you know, things that are underlying, health problems that maybe masquerade as shoulder pain or back pain or neck pain, but actually aren't mechanical back pain and neck pain. So red flags would be things like significant weight loss, and this is stuff that you'd ask your client rather than assess for. So significant weight loss, we're talking 10% of your body weight in less than 3
Okay, so would it mostly be during the consultation assessment? Yeah. Okay, cool. So, but
yeah,
I mean, also if they've gone through all of that and no red flags there have come up,
yeah,
but yet it's something that's like passed a quadrant test, but then they're still experiencing like higher levels of pain, higher levels of distress from, say, like a nerve loss or anything else. Is there anything we can do that sort of passed a consultation and quadrant test that is able to know whether that is a straight referral? Because some people may like get past these consultations, not throw up any red flags, but then nothing is like no like form of like mobilization, stretching, or relearning of mechanics is helping with the pain presentation. So I'd rather not be working with people who pass all form of like consultation, but have a pathology that hasn't been diagnosed currently, that we're not licensed to work with. It's purely because they haven't been to someone like yourself or someone who can diagnose.
I think that raises lots of really interesting talking points. So I think the first thing I'd say is that from a special test perspective, do you want to know what I mean by special tests? So, so essentially when we're assessing clients, we might use, we talked about a straight leg raise test. We talked about some of this neural flossing stuff. There's various special tests that we use to try and aid in our diagnosis. Now, the problem with special tests is they have various levels of sensitivity and specificity, which means that they are either more or less reliable than a conventional movement. So I think to answer your first question, there isn't any more testing that you can do to be any more sure this isn't a pathological process. If you've done your consultation and you've ruled out your red flags from there, and you've done your basic movement assessment and it hasn't provoked symptoms, then I think there aren't any more tests really that you can apply that will be any more or less sensitive than a quadrant test. I mean, a quadrant test in itself isn't particularly sensitive or specific. So that's the first point, that there isn't probably any better way to assess from that perspective. I think the other question it raises is this concept about pain. And I think we have to understand that pain, once you've been in pain for more than about 3 months, which is what we class as being chronic pain, you tend to find it starts to change your prefrontal cortex. It starts to make changes in your brain. Now, a lot of the people that you're seeing that are passing these movement assessments may have a degree of what we call central sensitization, which is basically the segment that supplies that part of their body. The volume has been turned up, and as a result, everything that's going into that segment has been interpreted as a painful stimulus. So even things like, the labels on their t-shirt on the neck, even that is a painful stimulus for a lot of people. Waistband on the trousers, if you've got bad back, a lot of people will say, I can't wear tight trousers, I can't wear a tight belt. And that's not because there's a pathological process going on, that's because they've got this central sensitization. And this central sensitization is basically the changes that take place in the nervous system that mean that not all musculoskeletal pain resolves with a little bit of flossing and a bit of stretching, because you're not retraining that nervous system. Now, I think to address the nervous system stuff, movement is obviously key, and that's why you guys doing what you do is so important. But I think you have to find things that are non-provocative. Every time you do something that reproduces their pain, you're just reinforcing the central nervous system's belief there's something wrong. So you have to strip things right back to the point where you're taking it down to its simplest component part. You know, if you're talking about flossing, well, a floss, it might be, you know, this kind of thing out here, or it might just be that you just flexing and extending your wrist. That might be enough for stimulus to start to get the nerve pathways moving without producing and provoking symptoms. So I don't think what I'm hearing is that you're dealing with pathological process. It sounds like you're dealing with chronic pain, and chronic pain by definition is difficult to manage because of the central nervous system changes. But the key to managing chronic pain is to make sure that you're breaking the movements down to the component parts that don't aggravate, and then reintroducing those movements back into normal movement patterns from there. Anybody else want to add anything at that point? Matt looks like he wants to say something. No?
For once, no.
Does that answer your question, Martin?
Yeah, it does. That's pretty much what I've been doing currently. Yeah. Anyway.
Well, I think the world of therapy, the world of fitness, and the world of assessment is, we'd like to believe it's a bit more robust than it's a bit more black and white than it actually is. I think the problem is with therapy and what we do as fitness professionals is there's not much black and white. There's just lots of shades of grey. And I think you should be happy in those shades of grey, in the grey, because there is, even with scans, you know, there isn't a definitive answer to be found. You know, we send people off very sort of occasionally for scans, and typically they come back and it might show they've got disc bulges, and they might opt to go down the surgical routes, and they come back after surgery, and even after they've had surgery on those disc bulges, it's made no difference to their pain sensation, because it wasn't that was causing the tissue. That wasn't the tissue causing symptoms. Anything you want to add to that, Aaron?
No, that's good. Yeah, I think a lot of it, I hate to say it, sometimes with clients is psychological. Like you say, if you've been in chronic pain, so 3 months, 3 months and more, a lot of it's going to be psychological. It's going to be embedded in their head now. You know, before they even do the movement, their brain is telling their body there's going to be pain. Yeah. So yeah, a lot of it's about, you know, not just saying, oh, you're fine, push through, because that's not what we're saying. Just psychologically, it can be a part of it as well. So giving them confidence sometimes, you know, we're going to do this exercise. You might feel a little bit of pain, but this is normal pain. You're going to have to just, you know, almost embrace it a little bit.
I think you have to be careful about psychological, because people hear that.
It's the phrasing of it, isn't it?
Yeah, people hear
trying to make sure they know you're not saying it's in their head.
It's in their head. Yeah. Which we are kind of saying, because the strain is in the brain.
Yeah. But it's not that it's imagined.
Yeah, pain's always real. You know, pain is, if you're experiencing pain, it is always real, but it's an output rather than an input. You know, it's your brain, something is being sensitized in your nervous system, which is relaying information back to your brain, which is either correctly interpreting it as a pain signal or incorrectly interpreting it as a pain signal. And that's why, you know, when you're in pain, and these people, I say a lot of guys that still try and push on with the squats and the deadlifts when they've got back problems, all they're doing is hardwiring that movement into that pain pathway. So every time they do a hip hinge movement, or every time they do a squat, their brain interprets that movement with a pain signal, and that starts to hardwire that in. So it becomes difficult. Then they're sitting down and it feels uncomfortable. They're standing up and it feels uncomfortable, because you've just basically associated a movement with a pain, you know, a painful stimulus.
Sometimes, like, not like bringing the fact or the word pain up can help sometimes.
Yeah.
You know, trying to just distract away from that. I think that's a strategy that I sometimes try and like get them to focus on, just not focusing on the pain, if that makes sense.
And I think sometimes if you're in pain, and I think sometimes, I mean, we did the same thing when we were rehabbing Dan's back. When she was having a really bad day with a lower back and a sciatica, we'd do an upper body session. We'd use that as an opportunity to distract. So you get the endorphin release, you get the production of, you know, all the happy hormones, and then as a result, you you find that dampens down your pain sensation in your back and in your hamstring and glutes. So there's always ways and means of working around these things. I think it's just trying not to be too hung up on the whole special. Is there a special test to demonstrate they've got a pathology? No, there isn't, is the honest answer to that. A good consultation, asking some questions, ruling out the possibility they've got any red flags. And I'll post some stuff on red flags later on today, so you've got a list of what we'd class as being red flag questions. That would serve you as well. And then just having some patience, just trying to make sure that they're realistic in their expectations, and that you're realistic in what you hope they can achieve.
Yeah, perfect. Cheers. That's
perfect.
Pretty much what I've been doing. So yeah, great to clear it up.
Right. I think this is the last question. This one was this is one for Phoebe, I think.
Yes.
Yes. So plantar pain, shin splints, from all the increased cardio. So I think part of it's low. And again, you'll all probably get this sentiment. I think a lot of people are embarking upon cardio programs without any previous history of running. I spoke to a guy this morning who's I think he's bigger than you, Eurus. And he's suddenly embarked upon hill sprints and started to get some medial knee pain. Now, previously, the only sort of cardio he did was walking. So you can understand from a local management perspective, there's obviously issues around that. I think in terms of, you mentioned, Phoebe, you've been wearing shoes that weren't...
It's from a client.
Right. Go on, tell me a little bit more about
that was a different question. So I think I sent 2 questions.
Yeah, one was for me, one was for Phoebe.
Yeah, from 2 separate clients. The one where she was wearing shoes too small for her, well, what she thought, she started getting pain on the top of her foot, at the bottom of her toes, and then it's gone into her ankle now.
So that's probably going to be a little bit of tendinitis. So the sheath on the toes, your tendons are covered in a sheath. And with the restrictive footwear, you're probably going to find that's going to start to irritate the tendon sheaths. When she moves her foot, ask her if she gets any crepitus, any sort of cracking, popping, weird sounds, because that's a classic sign in the feet and the hands of tendinitis or or whatever you want to describe it as. So
does the crepitus, does that work on every type of tendinitis?
No, it tends to be more where you've got tendon sheaths.
Right.
In your hands, in the back of your hands, you can get crepitus through there. In the tops of your feet, because those tendons have got a sheath around them. Lots of other tendons don't have sheaths. So you get what's called a tenosynovitis, which is the inflammation of the tendon sheath, which is what causes the crepitus, the cracking, the popping, the clicking.
Right.
For elbows, it's not the same for shoulders.
Knees.
It's what?
What about knees?
No, knees. The crepitus you get from your knees is basically some cartilage wear and tear. The clicking and popping from there is more joint generation as opposed to sort of issues. Go on, Matt. You're going to say something there?
I'm going to say, can that be synovial pressure shifts as well, like within the capsule?
Yeah, absolutely. I mean, I think the intracapsular pressure obviously determines what's going on inside the joint. So yes, it absolutely can be, synovial pressure changes. And things like surgery, if you've had surgery, they tend to cut through the joint capsule, which changes the inside the joint itself, which is why we tend to try and avoid people going down the surgical route. So from your first question then, Phoebes, I think it's probably a little bit of tendinitis, and I think she just needs to get some better fitting shoes to take the pressure off.
She said it were slippers, she thinks.
The slippers, wow, they must be fucking tight fitting if they're slippers.
It's the slippers.
Or are slippers high heels with little sort of feather boas on the front?
God knows.
God knows.
But then the other one is
one of my clients.
Jared,
Yeah, one of my clients. he's been getting shin splints, and he's not doing any other cardio other than walking. So he was a week out from his competition. So I've sort of slowly introduced food back in, trying to manage health and also his mental state as well. But sort of going down the path of just getting food back into a really, really nice place again. So he now, because he's put a little bit of weight back on, which is nothing major. We're talking since the lockdown. So 5 weeks. It's been 5 weeks since his competition should have been going ahead. So he's only increased body weight by like 4 kilos. So nothing massively at all.
Yeah. So not enough to cause significant problems.
No, not enough to cause like massive fluid, like water retention or anything like on his feet or around his ankles and shins. So I kind of, I thought it was more of a mobility and a stretching and that type of problem.
I think without seeing it's obviously difficult, but one of the things I'd get you to have a look at, and this is what I find with people who develop shin splints, is they usually head heel strikers. They usually tend to heel strike as their sort of first point of contact with the floor. Now, every time you heel strike, what you're having to do is using anterior tibialis and posterior tibialis to flex the foot.
Yeah, that's what I said.
Now, depending on whether he's got pain on the inside, which would be more tibialis posterior, pain on the outside, which would be more tibialis anterior, and on what you try and address. So, getting a foam roller, lacrosse ball, peanut mobility ball. I think we've got some stuff in our feed about mobilising the anterior shin.
Yeah.
Using that as a to address the tightness in there. But fundamentally, what a lot of people need to do, and what we're seeing a lot from the plantar fascia pain, is trying to address their gait mechanics. This is a good time, when you're at home, to have a look at how your feet are moving and actually how to get into more of a barefoot sort of situation. Now, with him, what I'd encourage you to do is get into find a piece of grass, 50 yards of piece of grass, and just walk barefoot across the grass. And it's the same if you were doing this from a running perspective. If you're running, jog across the grass and just notice how your foot lands when you're barefoot in comparison to when you're shod. And then try and replicate the way that your foot lands barefoot when you're back into your shoes. Because usually it's when I was in the forces, I got shin splints really badly because they teach you to heel strike when you're marching. And that constant dorsiflexion of your ankle puts a lot of pressure onto the posterior tibialis, anterior tibialis muscles. And as a result, you then tend to find it starts to pull on the periosteum that surrounds the bone and then causes shin splints or medial tibial stress syndrome, as it's otherwise known. So adopting some barefoot stuff, getting into midfoot land, not heel striking, because that's decelerating, that's pulling, it's a lot of ground reaction force through the heel, but it's also working those dorsiflexors really hard. And then doing some, either the peanut mobility work on our feed, and I'll send you the link when we come off.
Yeah.
Any other questions regarding feet?
No, just ask about pes cava. I've got a client who has been dealing with severe spasms in his calves for a long time. We're talking years. He's had quite a lot of investigative tests done, neurological tests, and nothing ever come back positive. So he's got nowhere with in terms of being treated at a hospital.
Which is typical. I mean, it's good from, so pes cavas, for those of you who don't know, is basically high arches. So instead of the foot being flat, you've got a high arch. And yes, neurologically, there usually is a neurological cause for that. You tend to find if he's been investigated to rule out the possibility, it isn't neurological. That's a big tick. I think, again, from him, I'd be encouraging him to, because what he'll tend to do is walk on the outside of the foot.
Yeah.
So I'd be encouraging him to spend some time at home foot, thinking about the foot as a tripod, making sure you've got contact through the first metatarsal, so the big toe, the side of the foot, and the heel, and just spend time in a what I call an active stance position. And that what I mean by that is standing with your feet straight so that you can create torque and tension through the external rotators of the hips. That aligns your pelvis well, but that it's a reteaching thing. He's going to have to learn to almost retrain himself to walk in a different manner. And I think this is a good time to start to implement that. I think I did a podcast with Chris a couple of days ago, which I think has gone out today, where we talk about active foot mechanics and active foot stance. So it might be worth looking into that, Becky. I'm going to listen to that because there's some stuff on there which you might be able to implement with him.
Thank you.
All right. Any other questions on feet, guys? That baby looks very happy there, Felicity. All right. Is that everybody's? Was that useful?
Yes.
Yeah.
Yeah.
Yes.
So how do you feel if we set up a closed Facebook group for the guys that have been involved in this?
Yeah. Yes,
And maybe in a couple of weeks' time, maybe next week or a week after, and I'm looking at Uris to tell me to give me some guidance here. We set up another webinar where we have another open discussion forum. And again, if you've got any other questions that arise at that point.
Yeah, sounds good.
Yeah.
Great.
All right. So thank you very much indeed for your participation, guys.
Thank you.
Thank you so much for having us.
Thank you, Aaron.
Cheers, Aaron.
Cheers, Aaron.
See you soon.
Aaron, can I? Aaron,
Yeah.
have you cut your beard off?
I have cut my beard off. Yeah. Yeah. I had COVID, and it affected my brain, and I cut my beard off.
Right. Okay.
Like Nathan's Britney Spears moment.
Yeah, I shaved my hair.
It's growing back, but yeah, it all came off. I was having one of those moments in time. Right, thank you very much indeed, guys. Pleasure talking to you.
Awesome. Cheers, Aaron.
Cheers.
Hello. Yeah.